Hi, I'm Huw Morris. I'm one of the neurologists at UCL. I'm going to talk about a clinical clue that I use when I'm assessing patients. I'm particularly considering the diagnosis of PSP. So we see a lot of patients in our clinic who may initially be thought to have Parkinson's disease, may have an alternative Parkinson's plus syndrome, for example, PSP, cortical syndrome, multiple system atrophy, or alternative diagnoses. Um, One of the things that I think is often overlooked in busy movement disorders clinics is cognitive function and the importance of assessing cognitive function in patients with atypical movement disorders. In PSP, it's pretty well recognized that there may be frontal dysexecutive features. So patients may have apathy, impulsivity, may have difficulty with flexible thought, with planning. They have a lack of insight into their condition. Typically in PSP, as compared to classical behavioral variant frontotemporal dementia, this will not be severe enough to cause problems with day-to-day activities or work in the early stages of the disease. But patients' relatives may have noticed a change in personality, a slight change in sense of humor, change in flexibility, a liking for more repetitive patterns. And often this is associated with decrease in speech output. It's important to assess this in the clinic, and it can be an important part of the differential diagnosis of PSP and Parkinson's disease. Very simple test, which I do in almost all patients who I see. Who I'm trying to assess for these conditions is verbal fluency. So I'd like you to give me as many words as you can, starting with a letter, not the name of people or places. So letter P, it would be postman, parcel, package, pigeon, pictured. But Peter wouldn't be allowed as the name of a person, and Paris wouldn't be allowed as the name of a place. So typically, having given that instruction to a patient, I will then set my stopwatch and start off with letter F. Normally, people should be able to generate at least 11 or 12 words reasonably rapidly that meet the criteria. Patients with frontal dysexecutive function often have poor initiation, poor self-monitoring, inability to generate a search strategy. PSP patients typically produce very few responses to this. Interestingly, the responses may be low frequency words, so quite obscure low frequency words. They may repeat themselves, maybe they may perseverate, and they may have rule breaks where they mention the name of a person or mention the name of a place. So this was looked at by James Rowe, team in Cambridge, looking at the ability of verbal fluency to distinguish between Parkinsonian conditions. And in their study, albeit with patients with well-established Parkinson's and PSP, there was a threshold of 7 words per minute, which was the threshold really most accurately distinguishing between PSP and Parkinson's disease. And so 7 words or less are clearly in the range of what we might expect patients with PSP. Thanks for listening to this clinical clue. I hope this is helpful in assessing your patients. Please feel free to be in touch if we can help with discussing clinical assessments of patients with PSP.